Okay, good morning, everybody. Thank you for joining us today. As always, these medical grand rounds are recorded, and we'll send that out to you as soon as it's available by tomorrow. We have a few updates today before we get into our main presenters. So we'll just jump right into that. Dr. Collins is going to talk about the COVID number updates.
All right. Let me make sure I share the right window. There we go.
Great.
Okay. Advance the slide. I was just going to briefly talk about, quickly, I showed this slide last week and mentioned that there was a slight, excuse me, uptick in the rates here in Santa Clara County as far as hospitalizations, but that is actually leveled out. So overall, that's good news at least. And in fact, our local counties, when you look at reopening, San Francisco is now in the yellow, which is the least restrictive, and San Mateo just joined Santa Clara and Alameda in orange, which is the second to least. That's based on positivity rate and case rates. As well as here at Stanford, our number of positive cases per week and hospitalizations have also kind of leveled out, although certainly not zero. So we're still living with the virus, but at least we're kind of sustaining a lower level now for at least a couple of weeks. And just quickly, the numbers in more detail. The census from last night was 10 COVID positive patients with 2 in the ICU. Aggregate numbers through October 25th. I'm not going to read through all of them for sake of time, but the trends are pretty much similar. Our ICU rate is about, or a little over 21%, death rate shown there, slightly more females than males, and we continue to have a pretty wide age range. And as far as race and ethnicity of our patients, we're over 50% Hispanic or Latinx, for those we know, which is almost all of the patients in the cohort. So wanted to be quick because we have some great presentations, and thank everyone who helps with these numbers.
Dr. Collins, thank you as always for joining us and keeping us updated here. Next, I'd like to move over to Dr. Bowman in charge of occupational health. He had a couple of things to mention.
Thanks. Just wanted to share the data update you from last week, sort of in congruence with what Will said. Despite what's going on in the rest of the nation and the world, we are maintaining our bubble. We have only 4 new cases of COVID positive employees over the past week. That's the lowest we've been. And so just keep up the good work, everybody. We can see if we can maintain this bubble. The other thing I just want to mention to folks who are out in the network in the South Bay, East Bay, is we're going to now start starting Monday, and you can self-schedule starting immediately if you need any COVID testing, employee COVID testing at Cancer Center South Bay and at Emeryville. We will have 3 days a week where that's available to you. You can schedule it on My Health. Thanks.
Thanks again, Dr. Bowman, as well, for always joining us. Next, I'd like to move over to Dr. Mahoney, who's going to talk a little bit about vaccination program for flu season coming. And also here.
Thank you. Good morning. I just wanted to first off thank everyone for those who were able to participate in the physician appreciation lunch we had earlier this week. Between the raffle gift baskets and the lunches, we had over 700 people participate, and it was just so great to see everybody in person after some time. But I did want to point out a new Santa Clara order that came out earlier last month. And this is a requirement of all healthcare facilities to require their healthcare workers to receive an annual influenza vaccination. And I know that many of us have already received it, so thank you very much. But if you haven't yet, there are a couple of ways that you can satisfy that requirement. And one is to send in your attestation. You can just send it to me with the location and date to Chief of Staff at stanfordhealthcare.org or my personal email, or you can send it over to flu@stanfordhealthcare.org, and we'll just make sure that the occupational health services records are updated. And then also, if you haven't been vaccinated, please go and get vaccinated. I provided the hours of operation for occupational health. And then if you go to a pharmacy, you can just send that attestation to me. If you have a medical or religious exemption, you can also send that to me. And then on the next slide, I provided some information that Dr. Bowman already mentioned, which is that if you are feeling, symptomatic, or if you're asymptomatic and desirous of a COVID test, I wanted to provide the updated information on how to obtain that test. Just spread the word, and these slides will be available as well. Thank you.
Thank you so much, Dr. Mahoney. Appreciate that update as well. And the last brief update we have as well is Dr. Ben Pinsky, who's going to provide some updates regarding testing for the upcoming respiratory viral season. Dr. Pinsky as well, thank you so much for joining us throughout the year.
Thank you, Errol. So we are getting ready for the respiratory virus season and combined testing with SARS-CoV-2. Fortunately, right now, respiratory virus activity is low. You can see the flu view up in the right corner for the US, and this is our SHC respiratory virus surveillance with basically, this is the SHC with basically only enterovirus and rhinovirus positivity. In the pediatric hospital, there's a little bit of adenovirus that we're seeing, but no flu yet. Because I am a bit paranoid, as you all know, we've been screening our negative SARS-CoV-2 specimens for flu, as well as RSV and measles, and they're all negative so far for the last approximately 2 months. And our respiratory virus surveillance graph will go up on the same webpage here that you can find all of our SARS-CoV-2 molecular diagnostic data and serology data for the season. So hopefully that will be up and available soon. So what we're doing as far as testing, as you know, COVID presentation in symptomatic individuals ranges from mild disease to very severe and overlaps significantly with other respiratory viruses. And we saw that at the beginning of the pandemic with work from colleagues here at Stanford showing that co-infection and co-circulation of other respiratory viruses was actually quite common with SARS-CoV-2. So for symptomatic patients, we are bringing on syndromic multiplex respiratory virus panels that include SARS-CoV-2. So this includes our standard respiratory panel with CoV-2. So this is all the various respiratory viruses, CoV-2 plus flu A, B, and RSV, and CoV-2 plus flu A and B. And these are for the rapid testing that will be performed at the core lab. And then for urgent and standard turnaround testing, we will also have COVID plus respiratory virus panel, COVID-2 plus flu A, B, and RSV. And these will be performed at the Hillview Virology Laboratory. The test codes are shown here. And remember, these are the rapid testing requirements. Just a reminder that reagent availability remains a limiting factor for rapid testing. We need to conserve those reagents and use them for only the patients that are most need that rapid result. So again, here are the different test codes, the turnaround times, where those patients are coming from that will receive those tests. These are the included targets, so the large panels versus the smaller panels, the platforms that are being used. And so these are the rapid tests being performed in the core laboratory. And these have been validated on nasopharyngeal swabs only. That's just a note for all of you that we still need NP swabs for these particular tests for rapid testing. These are the tests that are being performed at Hillview. You can see the turnaround times are slightly longer with 4 to 6 hours for urgent testing, in general, 24 hours for routine testing, but if volumes go up, it'll be up to, we give ourselves a little bit extra time. Again, you can see the panels. And we're using, because of supply chain issues, again, we are having multiple different workflows and tests in order to meet the testing demands. So please note that the following tests will no longer be available. This is just flu A, B, and RSV without COVID. And the respiratory virus panel at the core lab without COVID will not be available. Also, for lower respiratory tract samples, we're working on validating those. So for BALs and endotracheal aspirates, please order COVID-2 plus our lab, our respiratory virus panel, which is performed at Hillview. And then finally, testing for COVID-2 alone remains available. So those same test codes that we've had for some time. And this is for asymptomatic individuals, including pre-op, ambulatory, and various screening processes like for school, workplace, athletics, and then for symptomatic ambulatory patients that may not need testing for other respiratory viruses. So that's the update for respiratory virus testing. Just a brief additional update on impacts on other lab sections. So BioFire, bioMérieux is no longer supplying our reagents for the GI panel. Their manufacturing capacity is being utilized for SARS-CoV-2 testing. So they told us this at the beginning of this week, that they would not fulfill our orders. So we have a very limited number of remaining tests. So approval from the medical director of the microbiology lab, Niaz Benai, or our medical microbiology fellow, Christina Costales, is required to use these. We have less than 40 tests remaining. So the clinical microlab and send out section are working on new algorithms for GI pathogen testing. So hopefully we can resolve this and provide alternative testing as rapidly as possible. So thank you all.
Thanks so much, Dr. Pinsky, again, for all those great updates. And we can send out this info, if you'd like, out to everybody in the follow-up email. So perhaps we'll do that.
Great.
Okay, great. So moving on to our main presenters today. Before I do so, I just want to briefly mention, next week will be the first time we'll take a hold on medical ground rounds for a week, as you can guess, to give time for probably will be a quite busy week for us all. So we thought we'd be a good time to put a hold on medical ground rounds. We'll restart back up the following week with David Weiss, who's the Senior Vice President for the NBA, who's going to be talking about what the NBA basically did and went through to protect the players and related staff for the season. So we're looking forward to hearing that. This week we have quite a few great presenters today. I'm really happy to welcome. I'll start with Dr. Nidhi Rohatgi. She is the Clinical Associate Professor at Medicine, also by courtesy neurosurgery as well. She's a surgical co-manager, and she's in the section chief for the surgical co-management section of my own division, the Division of Hospital Medicine. She manages medical comorbidities and medical complications of neurosurgical patients in the hospital setting. And she has been really a great example of somebody who fires on all the different aims of our department and really the Stanford University. She's a wonderful teacher. She has been leading the research lead for the surgical management group since 2012, and now the director of clinical research for our Division of Hospital Medicine. And she'll be sharing more about that today. And she's really just a great teacher as well. So she really fires on all the cylinders of our aims at Stanford. So really happy to welcome you today, Dr. Rohatgi. We have, of course, Dr. Neera Huja. For many of you, if you don't know personally, know probably well throughout the year if you've been watching these medical ground rounds. She's been helping us keep updated throughout the year. Dr. Huja is clinical professor of medicine. She has been my mentor since 2008, Dr. Huja, since you were my advisor in my first year of intern year at the outpatient clinic. And then you became my advisor as the associate residency program director for internal medicine from 2009 to 2019. You were the director of the hospitals program from 2011 until you became the division chief of our division in 2017, as well as being the medical director of the Gen Med wards. And so she's also going to be joining us in the presentation today. So thank you so much for everything you've done, Dr. Huja. And then finally, we have Dr. Ahuja Blomkalns, who is the director, Stanford Medicine Professor of Emergency Medicine and the chair of the Department of Medicine since 2018, where she came from University of Texas Southwest Medical Center, where she was division chief of general emergency medicine and the vice chair of academic affairs and business development. And Dr. Blomkalns, especially thank you for you joining us today. I've appreciated really, I think a lot of us, I can speak for a lot of us, that appreciated all you've done for us, particularly this year. You've been a great voice on the town halls and the Stanford Live videos amongst other media. And we really appreciate your time today and joining us for this presentation. So with that being said, I'm going to turn over to all three of you. I think Dr. Rohatgi, are you going first?
That is correct, Errol. Thank you.
Okay, I'll stop sharing. You can go ahead, and thank you again for joining us.
Thank you, Errol, for the kind introduction. We have some really exciting trials to share today. I will first talk about tocilizumab and the COVACTA trial. Then Dr. Ahuja will talk about the NIH ACT trials. And finally, Dr. Blomkalns from Emergency Medicine will discuss the BLAZE-1 trial. I have no conflicts of interest to disclose. I will first talk about some of the biomarkers in relation to tocilizumab, such as interleukin-6 and C-reactive protein, then share some of the early studies of tocilizumab and COVID-19, and finally share some of the results from the COVACTA trial. Tocilizumab is an anti-IL-6 receptor antibody, and interleukin-6 is one of the several cytokines that are being studied as part of the host inflammatory response in COVID-19. Interleukin-6 cascade is initiated when interleukin-6 binds to either the membrane-bound or the soluble interleukin-6 receptor and a second transmembrane protein called glycoprotein 130. Now, this serves as a signal transducer of interleukin-6 with downstream signaling of other pathways, such as the JAK-STAT pathway that Dr. Ahuja will talk about later. Now, interleukin-6 is one of the most common pro-inflammatory pleiotropic cytokines that is released by activated macrophages and several other immune and stromal cells. The initial interest in targeting interleukin-6 in COVID-19 came from a study in China that reported markedly elevated levels of serum IL-6 in the range of 150 to 400 picograms per ml in patients with severe or critical COVID-19 pneumonia. The normal range for serum IL-6 is less than 8 to 20. These patients were presenting with fever and multi-organ dysfunction, and the possibility of a cytokine storm was raised. However, these high levels of serum IL-6 have not been confirmed in subsequent studies. A recent meta-analysis in Lancet showed that serum IL-6 levels in patients with severe and critical COVID-19 are profoundly lower than those reported in patients with ARDS unrelated to COVID, sepsis, or CAR T-cell induced cytokine release syndrome. It is likely that the inflammatory processes are mechanistically different in COVID-19 and these other conditions, such as ARDS and sepsis. Now, what about IL-6 levels in the lungs? A small study reported higher levels of IL-6 in the lungs compared to controls and patients with H1N1. Another meta-analysis hypothesized that it is possible that interleukin-6 may have a role in immune-mediated pulmonary thrombosis, and IL-6 blockade may be beneficial in selected patients with COVID-19, but more robust evidence is awaited. Tocilizumab is not a new drug. It has only been repurposed for use in COVID-19. It has been around for over a decade and approved for use in several rheumatological and inflammatory disorders. As I mentioned previously, tocilizumab is an anti-IL-6 receptor antibody. So the intuition would be that tocilizumab should be used in disorders where serum IL-6 levels are high. And if the treatment is effective, the serum IL-6 levels should go down. But counterintuitively, similar to COVID-19, many of the rheumatological disorders where IL-6 blockade has been approved for treatment do not have markedly elevated serum IL-6 levels, and serum IL-6 levels are not routinely measured to initiate or guide treatment in these conditions. The baseline serum IL-6 levels prior to administration of tocilizumab depend upon the balance between interleukin-6 production and the receptor-mediated elimination. My assumption is that in some disease states, the receptor-mediated elimination supersedes the interleukin-6 production, and this creates the variability in the serum IL-6 levels. It has also been argued that elevated levels of IL-6 may lead to downregulation of the interleukin-6 receptor with internalization and degradation of the receptor. So treatment with tocilizumab could perhaps be even more effective in patients with lower baseline levels of IL-6. Now, although the levels of serum IL-6 itself may not be as high in COVID-19, interleukin-6 is the predominant cytokine that stimulates the release of C-reactive protein from hepatocytes. And the levels of CRP have been reported to be high in patients with severe COVID. And as the patients improve, the CRP levels go down. So though this interleukin-6 pathway could be valid in COVID-19, the serum IL-6 levels may not be an accurate indicator to reflect its functional downstream effects. Several other non-cytokine biomarkers, including D-dimer and ferritin, are also elevated in patients with COVID-19 and have been proposed as potential predictors of disease activity or prognosis. Perhaps it is a combination of several biomarkers that may improve the predictive power for clinical deterioration, and such a nomogram has been proposed recently in the literature. Now I will share with you some of the early studies that use tocilizumab for patients with COVID-19. Of note, the initial interest in tocilizumab in COVID-19 came from observational studies, case series, or non-placebo controlled trials. I want you to carefully observe in the next few slides how these populations are different and how these studies were done in patients with different severity and stage of illness. Early in the pandemic, a case series from China on 21 patients with severe or critical COVID-19 reported dramatic improvements within hours or days of receiving tocilizumab, improvement in temperature, clinical symptoms, oxygen saturation, and imaging. Now, as a clinician, that would just make my day, but it is 21 patients. It is a different demographic. These patients were younger, with a mean age of about 58 years, and only 10% were on mechanical ventilation. COVID-19 was a multi-center, single-arm, open-label phase 2 trial that was conducted in Italy. It included patients with oxygen saturation of at least 93% or under on room air. The trial was conducted when the pandemic was at its peak in Italy. Verbal consents or even no consent and clinician discretion was permitted. About 300 patients were recruited in this trial. And once the recruitment for the trial were completed, about 900 patients were enrolled in a validation cohort. The investigators concluded that mortality at 30 days was reduced with tocilizumab compared to the expected mortality that was being reported nationally in Italy at that time, which was around 20 to 35%. So instead of 1 in 3 people dying, now 1 in 5 people were dying with tocilizumab, which is still a very staggering number. The rate of infections with tocilizumab was not higher than expected. The CORIMONO-TOCI-1 trial is another randomized open-label phase 2 trial that compared tocilizumab to the standard of care and was conducted in France. This one was not a large trial. They included 130 patients with moderate to severe COVID-19 pneumonia who were on at least 3 liters of oxygen, but not on high flow, non-invasive or invasive ventilation at the time of enrollment. In April, it was announced in the media that in this trial, there was a significant improvement in the clinical outcomes with tocilizumab. By October, the peer-reviewed results were published in JAMA Internal Medicine. The results from this peer-reviewed article show no difference in clinical progression at day 4. Maybe, if you push it some, a lower incidence of death or the need for high flow or non-invasive or invasive ventilation in the tocilizumab group at day 14, and no difference in mortality at 28 days. Multiple observational studies were also reported around this time. Several of them reported lower mortality in the tocilizumab group. So by this time, there appeared to be 2 camps. This was the first one, who opposed off-the-shelf use of tocilizumab. There were several concerns about tocilizumab, the design and rigor of these trials, the data analysis and data completion, different demographics, inclusion criteria being too broad. Should biomarkers of inflammation be included? What is the risk of infections? Even though most of the data on infection rates with tocilizumab comes from patients who were on this medication for a long term and not those who received only 1 or 2 doses of tocilizumab as is being given to patients with COVID-19. And then there was the second camp who felt a robust clinical trial is needed. So the question can be first answered on a global scale, and the patients should not receive tocilizumab outside of a clinical trial till more is known. So around March, Roche announced the first global randomized double-blind placebo-controlled phase 3 trial to investigate the safety and efficacy of tocilizumab in patients with severe COVID-19 pneumonia. The trial was called COVACTA, and Stanford had the opportunity to participate in this trial. This trial was conducted in 9 countries with patient recruitment between late March and August. 452 patients from this trial were included in the analysis. Patients were randomized 2:1 tocilizumab to placebo. The inclusion criteria was adult patients hospitalized with COVID-19 who had bilateral chest infiltrates on imaging and an oxygen saturation of 93% or under, or a PF ratio of less than 300. The primary efficacy endpoint for this trial was defined as a change in the clinical status on a 7-point ordinal scale on day 28. There were multiple secondary endpoints as well, including mortality at day 28. From the preprint that was released, at baseline, about 70% of the patients were male with a mean age of about 60 years, 60% were Caucasian, 60% of the patients were enrolled in North America and the remainder in Europe. About a third of the patients were on supplemental oxygen, a third on non-invasive ventilation or high-flow nasal cannula, and about a third on invasive mechanical ventilation. About 80% of the patients had one or more comorbidity at baseline. In the tocilizumab group, about a third received steroids compared to half in the placebo group, and about a third received antivirals in each of the 2 groups. A very few patients in each of the 2 groups also received convalescent plasma. The baseline serum IL-6 levels prior to administration of tocilizumab was around 200 picograms per ml and comparable between the tocilizumab and placebo groups. The serum ferritin levels were higher in the tocilizumab group. In this randomized placebo-controlled phase 3 trial, the primary endpoint of difference in clinical status at day 28 was not met. Among the secondary endpoints, there was some benefit among patients who were not in the ICU and not on mechanical ventilation at randomization. Though these results for secondary endpoints should be considered nominal since the primary endpoint was not met. Length of stay was shorter in the tocilizumab group, and the secondary endpoint of mortality at day 28 was also not met. For the safety endpoints, including infections, the rates were fairly comparable between both the arms, or only slightly more favorable for the tocilizumab arm. The conclusions from these recent trials so far seem to be that tocilizumab may hasten recovery. It may decrease the need for ICU, but no clear mortality benefit. So where do we go from here? Roche also conducted another global phase 3 trial that primarily enrolled underrepresented patients that unfortunately have been disproportionately affected by COVID-19. This trial is called Impacta, and the study design seems to be fairly similar to that of COVACTA based on the information that is currently available. In this trial, the primary endpoint was met, and the patients in the tocilizumab group were 44% less likely to progress to mechanical ventilation or death based on the results reported in the media. The results from the BACK trial from 7 Boston hospitals was also published in the New England Journal in the last week. This was a randomized double-blind placebo-controlled trial that enrolled 243 patients. The inclusion criteria had several biomarkers, and the patients were on less than 10 liters of oxygen at the time of enrollment. No difference was noted in day 14 or day 28 rates of mechanical ventilation or death or clinical worsening. The infections were lower in the tocilizumab group, similar to prior studies. There are over 30 clinical trials with tocilizumab that are still active on clinicaltrials.gov. The results from the observational studies do not match with that of the RCTs, and not all RCTs have been equal either. We have learned so much more about COVID in these past few months that will have a significant positive impact on the design of future trials, and every next trial may be better than the last one. What outcomes to study? What subset of populations? What should be the inclusion criteria? What should be the stage of illness? And how to even determine the stage of illness with the information that we see and hear such as the duration of symptoms or the need for oxygen or ventilation, or with the information that we don't see, such as the viral load or a variety of biomarkers. COVACTA was a valuable trial that studied this on a global scale, answered some questions on safety with 1 or 2 doses of tocilizumab, but with additional studies, hopefully, we can identify which subset of patients or what stage of disease tocilizumab may or may not be effective. We await the results of the recovery trial, where about 850 patients have been randomized to tocilizumab versus standard of care. The results from the remdactor trial are also awaited, where patients received a combination of remdesivir with or without tocilizumab, along with standard of care. Now, before I pass on to Dr. Ahuja, I want to thank our patients, their families, and several of my colleagues from all over Stanford who were instrumental in helping us participate in a global trial to study this drug. Thank you.
Thank you so much, Dr. Rohatgi. That was really excellent. We'll move on to Dr. Huja.
Thank you. And yes, Dr. Rohatgi, that was a phenomenal talk. Thank you so much. Good morning, everyone, and thank you for your time this morning. I'm looking forward to sharing some results with you. And I wanted to first disclose that I have no financial conflicts of interest and that this data is being presented with permission from our NIH NIAID ACT team under the leadership of Dr. John Beigel. All right, so ACT is our trial that I'll be speaking to you on today, and ACT stands for Adaptive COVID Treatment Trial. It's a multi-center, so many sites around the world, adaptive in nature, randomized blinded controlled trial looking at the therapeutics in patients that are hospitalized with COVID-19. You can see our sponsors here and the amazing study team under Stanford, both at Valley Care and the Palo Alto campus. Now, a few months ago, I presented to you the preliminary report of Act 1 on remdesivir. October has been a very dramatic month for remdesivir, starting with on October 8th, the final report being published, as you can see here. And it did indeed confirm that remdesivir was superior to placebo in shortening the time to recovery in patients that were hospitalized with COVID-19 infection. The median recovery time was 10 days versus 15 days with placebo. And as you can see here, the earlier in the course of the disease that remdesivir is given, the greater the benefit. Now, October also brought along the WHO Solidarity Trial, which challenged the efficacy of remdesivir and also looked at a few other repurposed antivirals. And I wanted to take a minute or so to show you some details about that trial in case you haven't read it. There are some significant limitations that it had. So the Solidarity Trial was conducted in over 30 countries around the world. The US was not a part of this trial. And it looked at mortality in hospitalized patients with COVID-19, assessing 4 repurposed antivirals: remdesivir, hydroxychloroquine, lopinavir, and interferon. And you can see some of the characteristics of the outcomes in the study here. Graphically, you'll see that this trial claimed that none of the antivirals appeared, or basically none of them really had a significant effect on hospitalized COVID-19 patients when looked at overall mortality, time to ventilation, or duration of hospitalization. However, this trial had significant limitations, starting with the fact that there was no placebo, which is needed to prevent treatment assessment bias. There was no double blinding, which we know is important to prevent information bias, treatment assessment bias, adherence bias, and follow-up bias. There was no rigorous data monitoring, which is key to ensure appropriate trial conduct and patient safety. The methodology of diagnostic confirmation of the infection was unclear, which is important to ensure that patients have an equal proportion of the confirmed diagnosis between arms. Additionally, there was no clear tracking of the timing of symptom duration before treatment initiation, which is key to ensure that the intervention is given at the same stage in the course of the disease. Furthermore, it was unknown what the baseline physiological severity of the patient's status was. The healthcare capacity status of the enrolling sites was unknown, which is important to ensure that there were equal resources between arms. There was missing data in this trial. And some patients, it seems, were required to stay in the hospital for the full fixed 10-day course of IV remdesivir, even if they were well enough to go home. And if confirmed, we know that this is an additional flaw because prolonged length of stay would always be biased against the drug. Finally, this release is only a preprint and was not peer-reviewed. So really, in a pragmatic trial, no matter how large the sample size, flaws in the study design do not exempt it from scientific rigor. And if you look at the Cochrane comparison of Act 1 for remdesivir and Solidarity, the WHO Solidarity trial was flagged in several domains and overall as a trial that's at high risk of bias. So given the scientific rigor, Act 1 does show that it's the remdesivir and the trial itself was at low risk of bias, had high quality evidence, and remdesivir remains a standard of care for hospitalized patients with COVID-19 pneumonia. Also in October, as recently as last Thursday, remdesivir became the first FDA-approved treatment for COVID-19. All right, moving on to our next act, Act 2. So this is the trial I'd like to spend some time on with you this morning, looking at baricitinib. And you can see that there were many sites around the world that participated in this trial, including, in addition to Stanford, including our very own Palo Alto VA, which was an independent site. Enrollment for our trial stopped on June 30th of this year, and we had a final N of 1,033 patients. So baricitinib. Our very own Mark Genovese actually published on baricitinib in 2017 in the New England Journal, showing its effectiveness in refractory rheumatoid arthritis. Why did we choose it? Well, it has a relatively short half-life. It's an oral pill. It has a well-established safety profile. So in addition to being approved for rheumatoid arthritis, it's been licensed in over 70 countries, and we believed it was a rapidly scalable intervention. Mechanistically, baricitinib inhibits cytokines and has potential antiviral effects. Now, as we know and we saw from our previous talk, that COVID-19 has stages, and if the early stage we can control the virus, the better, the earlier we do it, the better. And in the later stage, we need to control the inflammation. Fortunately, baricitinib controls the later stage and has potential antiviral effects helping with the early stage. On a cellular level, you can see that baricitinib, being a JAK inhibitor, inhibits both the JAK1 and JAK2 enzymes, which then decrease cytokine production, since these enzymes are involved with cytokine production, and then decrease the very dramatic inflammatory response that we see in COVID-19. Our study design was similar to Act 1, looking at hospitalized patients with COVID-19, and they needed to have evidence of lower respiratory tract infection confirmed by one of the following characteristics. Patients were randomized for IV remdesivir for up to 10 days, plus either placebo or baricitinib for up to 14 days. The drugs were stopped when symptoms were resolved or the patient was discharged from the hospital. And I mention this because there were times when symptoms were resolved and the drugs were stopped, but the patient was required to stay in the hospital for a few more days until a safe discharge and quarantine could be ensured. This is the Ordinal Scale that we use in our ACT studies. And the population that we enrolled is Ordinal Scale 4 through 7. And you can see that this population has varying degrees of oxygen requirements. Our primary endpoint was the time to recovery on Ordinal Scale. And I'll show you some more data on this. Now, these are top line results only. We are still waiting for the full analysis. But you can see that both arms were pretty well balanced when we looked at age, gender, pre-existing medical problems, and these are the top 3 that were listed here, and then the score on the Ordinal Scale. The primary endpoint overall looked at the number of recoveries and the time to recovery in the baricitinib group, which was 7 days, and the placebo arm, 8 days, with a statistically significant P and a rate ratio of 1.16. But let's break this down a little more. To orient you to this graph, these are the Ordinal Scales on the top, and you can see the baricitinib arm and the placebo arm for each of the Ordinal Scales. What I'd like to draw your attention to is Ordinal Scale 5 and 6. Take a look at the rate ratio in these groups, and I'll show you some more information on this in a second, but let's look at our secondary endpoint. So with this group, also looking at ordinal scales 5, 6, and let's look a little bit at 7, the odds ratios you can see here. And I'll show this to you more pictorially. So for ordinal scale 4, this is the group that was not on oxygen. We don't see a big difference really in the treatment arm on the top and the control group. And in the enrollment score you can see here is color-coded from blue to orange as we increase in severity. But what happens when we move to ordinal scale 5? This is the group that was on low flow oxygen. As you can see on the top, this is the treatment arm with baricitinib. The intervention arm had less progression to worsening of disease compared to the control and slightly greater improvement. The results are even more dramatic in ordinal scale 6. So this is the group that was on high flow oxygen, but not mechanically ventilated. There was a significantly better improvement in the intervention arm and greater improvement compared to the control arm. Less worsening of disease, greater improvement overall. To show you ordinal scale 7, same trend. Intervention arm had less progression to worsening of disease and greater progression to improvement. What about mortality? So if we look at the numbers, and I'll highlight them here to make it easier for you to see, although the hazard ratio did not reach statistical significance, there are some interesting trends. Take a look at the baricitinib group in ordinal scale 5 compared to the control, as we look at the Kaplan-Meier estimates of mortality over a 28-day percentile, and then ordinal scale 6, baricitinib versus control. How about safety? Fortunately, the safety profile of the intervention arm was relatively good. In fact, for most of the adverse events, you can see the baricitinib group was actually lower than the placebo group. The one area that I'll point out to you is the thromboembolic group. Now, we know that COVID does predispose to thromboembolism in the form of DVTs, PEs, and strokes. Baricitinib has a mild and minor side effect as well of being prothrombotic. So the slight increase that you see here is likely attributable to that. But as you can see, the numbers are relatively small. A few months ago, we had a grand rounds on the recovery trial looking at dexamethasone. Now, to orient you to this graph, the green is what we just talked about. So this was the mortality for Act 2. And the two trials are not similar in study design or patient population, but I wanted to point out some interesting trends as we look at the Kaplan-Meier estimates of mortality. Here is the intervention arm and the placebo group, and then looking for the similar trend in the mortality trial between intervention and the usual care. Let's also just take a look at the hazard ratios for Act 2, and then for the mechanically ventilated patients, the rate ratio for the recovery trial. And we'll come back to the corollary of that. Now, Act 2 recovery, and this is not recovery trial, but the recovery of patients with and without concomitant steroids is worth a mention. From this graph, you can see that there were fewer patients in the baricitinib remdesivir group that used steroids compared to the placebo group. Second, more patients receiving steroids recovered in the baricitinib and remdesivir group compared to placebo. However, we will acknowledge that the use of systemic steroids in Act 2 was non-randomized and a non-standardized intervention and was utilized by approximately 20% of the patients. There are pending results. So as I said, this is top-line data, and there are multiple secondary analyses and additional corticosteroid analyses that are forthcoming. But we can make some conclusions, starting with baricitinib, in addition to remdesivir, does indeed improve outcomes in COVID-19 when we look at the time to recovery, our primary endpoint, and ordinal scale at day 15, our key secondary endpoint. Those that are hospitalized with COVID-19 requiring oxygen, so low flow and high flow, but not mechanically ventilated, appeared to have the greatest benefit. However, it is unknown if baricitinib is better or worse than dexamethasone. Like we showed, the studies and the populations are not comparable in design, and based on the hazard ratio, each may have its own optimal population. So baricitinib may indeed be better for the low or high flow oxygenated group. Dexamethasone may be better for the mechanically ventilated group. Our ACT team is actually working on the full analysis and the manuscript is currently under review, but it begs the question that further studies are needed. Should we compare baricitinib and dexamethasone in a subsequent ACT trial? I wanted to mention that ACT 3 is currently enrolling, and I really want to give a shout out to our Valley Care team under the auspices of Evelyn Ling, Minjung Go, David Svek, and the amazing SCCR team that's supporting this trial. ACT 3, we're looking at interferon beta, which is a sub-Q drug, and we hope to have some results to share with you early in the new year. But back to baricitinib versus dexamethasone. Should ACT 4 look at this? Could we enroll in such a trial? More specifically, would physicians, primarily ICU docs, feel comfortable enrolling in a trial that compared dexamethasone in the mechanically ventilated population or some of the sickest ICU patients versus baricitinib? So more to come on that. And finally, I want to thank our amazing study team. Everyone that you can see here has really contributed over many months for this adaptive trial, and I'm very grateful for all that we've accomplished. Thank you very much, and I will turn it over to my colleague, Dr. Andra Blomkalns.
And thank you as well, Dr. Huja, again for that presentation, and Dr. Blomkalns, we'll move over to you. And to everybody, as Dr. Blomkalns loading her slides, thank you for the questions. I'll send, if we don't have enough time, I'll send some of these questions out to our presenters and try to get some follow-up answers for you all. And I know, Dr. Huja, one of the questions just popped up. You were just kind of talking about the need to compare dexamethasone and to these other immunomodulators, and I think that's a good point. One of the questions was asking about.
I'll answer some of the questions on the chat to keep the
great. Thank you.
Thank you very much for inviting me for this presentation. It is really an honor. My name is Andra Blomkalns. I'm the professor and chair of the Department of Emergency Medicine, and I've had the pleasure of working with many of you during this COVID pandemic. So for the goals of this presentation, I'd like to focus on a few key facts or a few key notions. One, simplicity over complexity. We've heard a lot about individual COVID trials, a lot of them in competition essentially for the same patient population. And the goal is to describe the strategy of the ongoing BLAZE clinical trial. We've heard several instances of, in some ways, reliving the past and considering the scientific approaches to answering these questions surrounding neutralizing antibody therapy. And then next steps, what do we look towards the future? And what can we expect? And I share Dr. Pinsky's paranoia that we are not out of the woods yet and that we can look forward to a robust and active respiratory virus season. The conundrum. COVID-19 has no cure. It has no prevention. It is a very complex multi-system disease. There have been multiple therapeutic candidates proposed and investigated with a broad system biology, including an assault on the inflammatory response system, including IL-6, CRP, and multiple other cytokine pathways. As of last night, there are 65 trials in clinicaltrials.gov of SARS-CoV-2 or COVID immunotherapy. We are revisiting repurposing of existing agents and learning lessons from immunomodulators from sepsis, which we have been contending with not all that long ago. One notion is that neutralizing antibodies are a reasonable approach for medical therapeutics. Examples from the past include ZMapp, the 3 chimeric antibodies treating Ebola, and setting a precedent for monoclonal antibodies with low viral loads. Neutralizing antibodies have also been proposed and successfully investigated in a prophylactic setting. The first monoclonal antibody approved by the US FDA against RSV was recently approved for preterm infants and children at high risk of infection for RSV. The trials are challenged, however. We've had basically a cataclysm of multiple trials with varying methods, varying stages of disease, sometimes marginal statistical power, varied control groups, lack of randomization and interim analyses, safety profiles, including the phase and the stage of illness, which has been brought up in other presentations. The data that I will show to you is an interim analysis, top-line data that has not yet, in some cases, been published, and there is an embargoed publication that will be coming out tomorrow regarding the combination therapies.
Audrey, can you hear me? I think it froze.
I am. I think my presentation has frozen. I apologize. We will continue going.
No problem. These things happen.
I'm not exactly sure what has occurred.
Is your computer frozen, or perhaps it's just the Zoom?
I am checking. I am not sure. Let's see.
What I can do is, yeah, it looks like it might have just, looks like everybody else is, it's just your computer might have frozen the video. Ahuja, you could, if you could email me, what I can do is, if you have a couple questions, you could email me the slides and I can try to put them up from my side. Yeah, she might have frozen out. Audrey, can you hear me? Yeah, I think her side might have frozen out. That's okay. While we wait to see if she comes back, maybe Dr. Huja, Dr. Rohatgi, there's a couple questions here. Maybe we can field a couple of those. Good. Great.
Yeah, we're happy to take questions while we work on Andra's slides.
Dr. Huja, do you want to expand a little bit more? I know I see Dr. Barry and Raj, you already answered some of the questions about.
I'll answer them live, though. I think it's worth it.
Yeah, that'd be great.
So Dr. Barry, in her global health role, looks at it from a very wide perspective, which is spot on. Baricitinib is indeed an expensive drug. It's about $94 a pill, while dexamethasone is much cheaper, up to anywhere from $2 to $4 per pill. And that is something that we have to consider as we look at a potential Barry versus Dex trial. Another question that was asked was, how do you choose which interferon to study? There was a Science article that was published a few months ago that showed that interferon alpha and interferon beta levels were low in patients that were infected with COVID. And so based on some of that data and some other analyses, we chose, the ACT3 group chose interferon beta to study. Now, interestingly, we had to, on that trial, stop enrollment in Ordinal Scale 6 and 7. There were some safety signal concerns as the DSMB met to review the initial data on interferon beta. So we're now enrolling for Ordinal Scale 4 and 5, and we'll have results, like I said earlier, in the new year. There was another question looking at from Rishi Raj saying, high-dose Dex does not benefit milder patients. My limited experience with steroids is that low-dose steroids are looking possibly at benefit in early mild cases. Any studies looking at this? So Dr. Raj brings up a great point. Now, the NIH guidelines have provided some guidance around who should receive steroids in patients that are hospitalized with COVID-19. There is so much variability across the world on how this is distributed, even in our own country. So in the East Coast, there was a colleague who said that the EMT docs are giving steroids to people in the ambulance if they know they have COVID-19, regardless of the severity of their symptoms. Whereas others are saying that they really withhold steroids until the patients are intubated. So much variability despite there being guidelines. At our own institution at Stanford, earlier this year, we had a multidisciplinary approach where we wrapped experts in from the ICU, ID, hospital medicine, and emergency medicine. And we came up with our own protocol, which ID has been very helpful in educating our providers that are taking care of patients with COVID-19 on, showing that we should limit dexamethasone to patients who are on 4 liters of sustained oxygen or higher, rather than giving it to them at any course of their disease.
That's great. You kind of touched on this a little bit, if you didn't already. David Katzin asking why not Dexa plus or minus baricitinib?
So that is one thing that we are considering for Act 4. And I think this would be a trial, if we can get the cost issue addressed, would be very, very important to address, because the data that I showed shows that this is probably the next corollary trial that's indicated.
Gotcha. Rhonda Larson asks, have we looked at IL-17 immunomodulators in patients with COVID or in patients that are already on them as they increase risk for being infected with COVID? Or are they at increased risk of getting infected with COVID? Basically just IL-17 immunomodulators in general.
Yeah, I don't know if anyone else wants to answer that, but it's not a standard lab test that's being ordered, but fortunately some of our biobankers, so Dr. Kari Nadeau, Angela Rogers, et cetera, do have samples that are being assessed in a deeper dive. And so I think some data on that should be forthcoming.
There's a question here, a recent grand rounds, of course, Lambda trial. I don't know if you have any thoughts on interferon Lambda, seems to have fewer side effects as well. Any comments from that perspective?
Well, I think last week's grand rounds showed that, it was a negative trial. So I think that, that's not something that's being considered at this time.
Yeah. Okay, great. The question just popped up. The recommended dose in the COVER trial is 6 milligrams for Dexa. In patients with severe disease, have you used higher doses of steroids?
Again, I think that's something that might be somewhat variable. In the ACT trial, only 20% of the patients received steroids, and it was at varying doses. We would have to take a look and see what, the doses that patients at Stanford are receiving, and we can circle back. I think there is some standardization, but I'd like to confirm with our intensivists before responding.
Awesome. Well, let's see if anything else pops up here. Another anonymous question. In terms of side effects, is there a timeline in which you expect to see side effects, short-term or long-term, and what are some of those effects?
For which drug?
I'm assuming baricitinib, but it's not specified here.
Okay, sure. So, baricitinib, the half-life was relatively short, and we gave the drug for up to 14 days, although most patients did not receive it that long, just looking at the number that we had in Ordinal Scale 4, 5, and 6. The side effect safety profile I showed, showed that the only main side effect of baricitinib that we needed to consider significant was the thromboembolism, but everything else was relatively safe. And that's actually in part why it has been approved for rheumatoid arthritis, as well as why we used it for Act 2.
Gotcha. Dr. Huja, Rohatgi, Dr. Blomkalns might have the answer to this, but Lilly, as you know, recently discontinued the trial of the antibodies for inpatients. Dr. Berry is asking about safety issues. I thought it was less of a safety issue, just didn't show an effect. They're still doing trials of lots of other trials, but I think those patients were up to 12 days diagnosed before they started on the antibody. So it might have been just too long of a time course to get the effect. Here's Dr. Blomkalns is joining back in.
And while Dr. Rogers from the ICU just answered the steroid question, that they do not use higher dose steroids in the ICU. So thank you, Dr. Rogers.
Thank you. Dr. Blomkalns, welcome back. Can you hear us?
I can. I greatly apologize. This has never happened to me before, and I'm deeply apologetic. Perhaps the group would consider inviting me back for a short presentation some later time.
I was gonna say, we are more than welcome to come back. We were just talking about answering a few questions anyway, so no problem at all. I'm sorry that happened to you, and it happened, so no problem. We're just about a minute left. I was asking one question. Maybe we'll just end on that. You might have some input on the Eli Lilly trial, that Epsteller antibody that was recently stopped, the trial in hospital. I guess there was a safety issue was reported, Dr. Berry is mentioning here. Any thoughts on that one?
So the party line from the company or Lilly is that it was based on lack of efficacy of using that antibody along with remdesivir in an inpatient trial. So none of the trials using LY-CoV555 or bamlanivimab were stopped. The notion was later determined to be a non-severe adverse event and a clinical event that needed to be addressed, but not severe enough to close down all the other trials using that antibody. So it is peculiar because the press certainly is focusing on active 3 and its cancellation. However, the monotherapy and both the combo therapy are still being utilized and enrolling in all trials across all levels.
Okay. Oh, thanks for that info. We're at 9 o'clock now, and we have a relatively hard stop today. So I'll go ahead and end it now and just say thank you again to all three of you for joining us today. Dr. Blomkalns, you're more than welcome to come back, and I'll send you a message and see if we can schedule time for you to come join us again, share more information on that. So thank you as well, all of you, for your presentations today. Thank you to all the panelists for the updates and for sticking around in the background as well to help answer any questions that pop up. A reminder that we do have no grand rounds next week. I hope everybody has a good week next week, and we'll see you all the week after that. Thank you and have a great day.